Hi, it's a pleasure to be here. I'm Professor Imam, one of an upper limb consultant based in London, and I'm a professor and the medical director of a digital health center in London called the Smart Health Center. It's a pleasure to be here, and I'm very grateful for SICOT for the very generous invitation to talk about rotator cuff tears. So, this is actually our podcast. It summarizes a lot of orthopedic issues and can be helpful if you want to hear it. So, the challenge we have in shoulders is the shoulders are a complex problem, a complex joint, and there are different pain generators based there, ranging from labrum to cuff to impingement to mechanical issues to other issues like we are aware of the kinetic chain issue and others. And so when you see someone with a shoulder problem, especially a rotator cuff tear, and for exam purposes, you have to understand the complex anatomy and the different issues we find when we examine someone with shoulder pain. And the shoulder complex is composed of three anatomical joints: the glenohumeral joint, acromioclavicular joint, and obviously the sternoclavicular joint. Plus, others would regard the subacromial space and the movements then to be a physiologic joint, and more importantly, the scapulothoracic joint, which is crucial there. And so, when you assess someone with a rotator cuff problem, it is crucial to understand the complex anatomy and the different interactions of the different muscles acting on the scapula, deltoid, and other muscles that can be involved. And it is important to have a bespoke approach to everyone you see, which is crucial when you assess a patient with shoulder pain. It is very common. We see it all the time. It is the third most common musculoskeletal problem. And for me, I look at it as four clusters. In order to diagnose in your clinic or for an exam purposes, you have to understand the history examination, undertake your special tests, as well as the investigations. And that will give you a clear idea about what's happening. First question I ask the patient is, where is the pain? Because as you can see in this picture, it actually can give you crucial and very important information about what's happening there. And always, always, always don't forget the neck and what can happen from, and that the pain might be referring from being referred from the spine. And that's why almost in every patient I see with shoulder pain, I examine the neck and assess it. And as you can see, there it can be related to different neck problems. And actually, rotator cuff disease, some regard it as a combination of different problems that we see in clinics. But first, where is the pain? And you can then move and ask, is there a history of trauma? Because that can give you a good piece of information about what's happening there. And the second question is, how old is your patient? Because what you see in a child can be different to what you see in someone middle aged or an elderly patient. And another important bit that I do then afterwards, if I'm doing quick screening, would be the range of motion, assess the shoulder, starting actively and then passively. And that also will give me a very good piece of information, because if they cannot move it themselves, can be a tendon issue. If I cannot move it for them, that's a frozen shoulder or arthritis. And then, is the pain related to the movement? Because pain at each movement can be related to a different problem. So, if you're doing impingement assessment, we all are aware of the painful arc test, which is pain between 60 and 100 degrees. If the pain is at the end of range of motion on top, that's possibly related to the acromioclavicular joint. And then we need to do special tests. And special tests is either you test for a tendon power. So if the tendon is weak, that means it's torn. Or if you support and correct a deformity, and that tells you that the tendon is not working there. And so this is a near sign and the near impingement test. Hawking-Kennedy test for assessing subacromial impingements. And then you can cross chest adduction, will give you information about the acromioclavicular joint, and the patient should be pointing to pain on the acromioclavicular joint. And then you can proceed with your functional assessment of the different muscles by assessing them and assessing the power and whether the tendon is intact or not, or whether it's functional or not, because patients might not be able to move their shoulders because of weakness or because of pain inhibition. And that is also something to keep. So supraspinatus test, we have different tests there, which is very common. The job test, and which is in the assessed, and then you can assess the infraspinatus tendon with arms by the side, and assess external rotation of resisted external rotation. The lag sign is an important sign here for infraspinatus tendon, where you externally rotate the arm and then the patient cannot keep it there, and that applies to every test we do. You assess the teres minor in the hornblower test, then assess as a subscapularis, an internal rotator of the shoulders. There are different tests described there. I will then move and move on and assess the long head of biceps, which is not always clearly palpable, and the pathology involved with it should be considered, especially if the patient complain about tenderness in and around the anterior aspect of the shoulder, just under the acromion. And crucially, always examine the patient from the back. Scapular dyskinesia and abnormal motion of the scapula from the back is a very common issue that we see all the time. There are different reasons. Some of them are traumatic, some are traumatic, and some are structural, and others are physiological, which is beyond that talk. And it is easy to assess it. All what you need to do is actually to look from the back properly, and you can see it there. And it is obvious, and there are a lot of issues you can diagnose then. And as I mentioned earlier, always examine the neck. So, for me, there are 3 P's when I actually see a patient with shoulder problem: the pathology, the patient, and the participation and their activities. And then looking at the shoulder joint, it is a complex joint. The humeral head contacts around 30% of the glenoid surface, with the glenohumeral index of around 0.5 to 0.75. And the glenohumeral joint is inherently unstable because there is a large range of motion and relatively small contact area between the humeral head and the glenoid. And only 30% of the head articulates with the glenoid surface at any time point. And that makes understanding the osseous constraints vital for clinical application. Then, one important aspect of the rotator cuff is the concavity compression mechanism, which is a primary stabilizer in mid-range of motion, where the labrum plays a critical role by increasing the socket depth by approximately 50%, and the anatomical augmentation resists translational forces and improves stability, particularly during functional overhead movements. And that's why when you see someone with rotator cuff problems, they will be struggling. Finally, negative intra-articular pressure contributes to stability by creating the vacuum effect. This suction seals enhances the mechanical resistance against distraction forces and underscores the importance of joint congruity even before muscular stabilization is involved. Static stabilizers, as we mentioned, are the ligaments and the labrums, and dynamic stabilizers are the rotator cuff muscles and other muscles working on the shoulder. So, understanding the anatomy of the rotator cuff is essential for diagnosis and surgical planning. The tendinous unit, which is supraspinatus, infraspinatus, teres minor, and subscap, forms the rotator cuff around the head. They insert, as you can see in these pictures, as at precise location on the humeral tuberosities. The supraspinatus inserts at the highest point on the greater tuberosity, while the subscapularis attaches to the lesser tuberosity. These are key footprints. Surgeons, we need to reconstruct when we're repairing it. This is a very good paper that I would recommend you go and read about the different insertions of the rotator cuff and the action plans. So back to what we call rotator cuff disease. You can have someone with impingement, and we tend to move, we'll go through it quickly. Impingement, we manage it with physio mainly. Steroid injection can happen. Subacromial decompression is not needed almost in 99% of the time. And a lot of these patients will just respond to a home exercise program that you can give them a link and they can do it. And then patients can come with other issues like calcification, and calcific tendinitis is one of the top diagnoses you can see. And actually what we see now a lot is the parpotage subacromial parpotage, which simply means a radiologist will undertake an ultrasound scan, inject saline in the calcium and calcium deposits, and then aspirate and inject steroids. And obviously if it fails, we can go do arthroscopic release, as you can see in that video. But it is irrelevant, but it can be part of the issue. Partial thickness tears, these patients, I'm not very keen on doing steroid injections. We have different options ranging from completion and repair, biocollagen patches, which is becoming common as well. And then patients with full thickness tears, where we will discuss what to do for them over the next 10 minutes. So if you see someone with full thickness tears, as you know, we can classify according to size. Is it degenerative? Is it traumatic? Is it partial? Or is it full? Because they can be that partial thickness, then we subdivide as are they articular side, are they in the substance of the tendon, or pearsal side, and they are graded usually from 1 to 3 depending on the portion of tendon thickness involved. while full thickness tears extend through the entire tendon, creating a communication between the articular and the bursal sides. Classification systems are essentially good for guiding treatment. Tests can, as we mentioned, can be categorized in that, and there are different way of categorization. Muscle quality is possibly the most important because that can detect the repairability of the tendon and what we need to do. The morphology refers to the shape and the orientation of the defect, which you can see in this slide. It's important to have the muscle quality because that tells you how much of the tendon is tendon and how much of the tendon is fat. And obviously, a fatty tendon wouldn't heal, while a good quality tendon full of tendon tissue would definitely heal. So, MRI, definitely the my choice. And actually, age doesn't really matter that much. It has no rule on what would be the outcome of surgery if you're going to do it. And keyhole surgery is becoming very, very popular nowadays. Not very popular. This is the mainstay of treatment, at least for me. And we found that for large tears, a double row would be a better option. For small to moderate tears, a single row is as good as a double row. In managing these issues. What about if the tendons are irreparable? We have different options. This includes precapsular reconstruction and my preferred option, which would be a tendon transfer. So if you look at this patient who's 54 and a builder, we've done an MRI scan and he had and there was no tendons remaining. You can see the occupation index and there is advanced fatty infiltration here. Obviously, when we went in, there was no tendons to repair, and all what was needed was debridement, which helped him for a few months. But then we ended up discussing options for tendon transfers, and my preferred transfer is the lower trapezius transfer, mainly because of the function of the lower trap, as you can see in these cadaveric dissections, which acts in the same line of pull. And for this, we use a tendo Achilles graft. There are other options like latissimus dorsi, which is also can be helpful. So you attach the lower trap on the back, attach it inside the shoulder, and you can see it. Actually, this is another view few months down the line, and you can see the tendon acting as a rotator cuff tendon, and we are actually present. We have a lot. Uh, we have excellent outcomes using these kind of transfers, and so this is also an important option that can have when you're seeing these patients.
Yeah.
And
Awesome.
actually,
Yeah. Go
you
ahead.
can see the
Uh,
the
you take it from Harvest, showing
tendon
that he's
is
flexing his shoulder.
actually working properly. So we're running our we run a master course in London on tendon transfers and complex situations in the shoulders. This year in 2026, we're doing it in July. Check the ORUK website there if you are interested. What about patients who develop arthritis after rotator cuff tears, which was irreparable, and the patient have advanced arthritic changes? What happened here? That it's rotator cuff arthropathy, which is a unique condition characterized by massive cuff tear with progressive arthritis, loss of dynamic stabilization from the tendons, allowing the humeral head to migrate superiorly, changing the joint biomechanics and causing cartilage degeneration. You can see that in elderly people, obviously, and we can see it more and more because of demographic shifts and advances in diagnostic imaging. You can see superior radiographic analysis here gives you key insights into the biomechanical failure patterns of rotator cuff arthropathy. As the rotator cuff loses function, the humeral heads migrate superiorly, an unmistakable hallmark on plain radiographs, as you can see on the right side, and the superior migration leads to two characteristic morphologies: femoralization of the humeral head and acetapularization of the acromion. These patients will present to you usually elderly patient, progressive pain, shoulder weakness, and pseudoparalysis, which is an inability to actively elevate the arm despite the passive range of motion. There are different treatment options for these patients, and obviously, the treatment can start with physiotherapy, steroid injections, and eventually a shoulder replacement. Another case study, you can see another patient, marked arthritic changes. You can see the radiographic presentation we've discussed earlier. CT scan is my imaging modalities that I do for them, and usually these patients will struggle, will have pain, pseudo paralysis, and other issues, and significant weakness. So they lose the function, and the only option for them is a reverse shoulder replacement. We do have other options now. There are many modalities. This is my standard operation now, using augmented reality in doing reverse shoulder replacements. And there are many other options. So, to finalize this presentation, we have a lot of options, we have a lot of presentations. It is bespoke treatments to what the patient have, and a plan, and understanding the anatomy, understanding why you're doing each treatment, that will make your decision sound in the exam and in real life. Thank you very much.